of this university webinar series. This day, we have an extremely sensitive and a unique topic. It says, modern medicine, the conflict between the art and the science. Many of us will be given to a doubt as to what modern medicine is. Is medicine an art or a science? And many of us tend to think medicine is a science. I'm not here to define if medicine is a science or an art. I suppose Dr. Mohan Kameshwaran would do that today. But what essentially is medicine? To put things in a nutshell, medicine is something to do with control of disease and control of death. At least that is what mankind thinks of medicine. When we study the age-old myth that the milk ocean was churned by the Devas and the Asuras, and the nectar came out of the milk ocean, and there was a fight for the nectar. The concept that disease and death will have to be controlled also started. The acquisition of the nectar or the efforts to acquire nectar were in a way a fight against disease, against old age, against aging, and all those phenomena which are related to disease and aging. Someone defined medicine as scientific study that is practiced as an art. Before I request Professor Mohan Kameshwaran to deal with the topic of the day, I would just like to remind the audience of certain basic facts. Fact number one, medicine deals with skill acquired by experience. Like so many other fields, medicine is one field. We think in terms of an experienced doctor. Someone with less experience is not preferred. If experience is a factor that determines practice of medicine, can experience be demarcated and put only into the compartment of science, or will it stride over art also? Chittiramum kaipadakkam, Sendamilum naapadakkam, Vaithadoru kalvi manappadakkam, said Avayar. Art requires perfection, and perfection comes from experience. If so, is medicine an art or a science? Fact number two, it is generally said science should be referable, repeatable. With regard to medicine, most of us will know half of what is true today will not remain true in the next 5 years or 10 years. Things will change. Things have changed. In such a case, can medicine be defined as science or should it be made an art? Fact number 3, medicine deals with human emotions and reactions. Many of us will definitely know a medical person is able to practice not primarily because of the knowledge alone. Dr. Ranjit will endorse me when I say a doctor will also have to be a kairasikarar to lure patients. It is not plainly the knowledge, the amount of knowledge, the quantum of knowledge, but many other things which are not exactly definable. When you say a kairasikarar, I do not know how to define that kairasi. In what quantum or what measure can you refer? It is not something that can be measured in a balance. Fact number 4, the receiving end is as dynamic and fluid as it can be. Say, for example, if it is electricity, right? You switch something on, then the light gets lit there. The bulb gets lit. The tube gets lit. The tube or the bulb that receives electricity is just the same. It does not react. It reacts probably by getting lit, but then it does not react by emotions. Here in medicine, we have the receiving end, the patient who reacts emotionally. It deals with a lot of emotion, so it is dynamic. You do not even know how a person will react. The same person might react differently to 2 different doctors. When so much of flexibility and variability is part of the game, can medicine be labeled a science or an art? And with such a unique topic today, I'm extremely happy that Professor Mohan Kameshwaran would be discussing with us and also enlightening us on the conflict that remains between art and the science in the practice of modern medicine today. What do I say about Professor Mohan Kameshwaran? Do I say that he is an ENT surgeon of repute? A man of expertise and eminence with a quiver full of awards? A teacher of quality? One who belongs to a very famous medical family? We all know his mother, his father, and maybe some would even remember his grandfather. So a man who belongs to a medical family, how do I say, what do I say? I would take privilege in introducing Professor Kameshwaran as someone who's very close to this university, because he is the descendant of the first family of this university. The first family of this university is the family of Professor Lalita Kameshwaran, the first Vice Chancellor of this university. And sir, we take privilege in welcoming you today to this university, which is the nurtured child of your dear mother. If Madam Lalita Kameshwaran nourished you, she also nourished this university. In a way, this university is your sibling, and we take pride in welcoming you, sir. We are waiting to hear from you. And thanks very much for being with us today. Welcome, sir, and the floor is yours.
Thank you, madam. I'm deeply touched by your very kind words of introduction. Most respected Madam Vice Chancellor and the officers of this very esteemed and revered university. It's a great privilege that you have afforded me today, giving me this platform and asking me to talk on a subject which is very dear to me. Let me take a few minutes to share my slides. I hope it's on your screens now.
Yes, sir, it is.
Thank you so much. Now, before I talk, I want to go back about 25 years and narrate an incident because that probably will explain why I chose this topic. I was sitting in the surgeon's lounge of a very famous corporate hospital and having a cup of tea after a particularly difficult surgical case. When they suddenly, a couple of hospital workers brought me a CT scan and a lady along with that. And when I saw the scan, there was an osteoma in the frontal sinus. So I looked at the scan, I looked at the lady, and then I said, well, you need to have a surgery, and I'm going to do this kind of surgery, and so on and so forth. And she said, thank you. And then I said, oh, you go meet my anesthetist, and dismissed her. In the corner of the same lounge sat the doyen of neurosurgery, Professor B. Ramurthy, was my guru and one of my respected mentors. I literally used to worship the ground he used to walk on. So he was reading a book. He closed the book, took his glasses, his characteristic gesture, and looked at me and smiled. And he said, you passed the test on the science of medicine, but you failed in the art of medicine. So I was a bit perplexed. I looked at him, and then he said, let me tell you a small incident. A few years ago, just like you, I was sitting here and a lady was brought and with a scan, it showed a meningioma, a frontal meningioma. And I looked at it and I said, look, you need to have this tumor taken out. So, you get admitted, I'll sort it out. She looked at me for a minute, that is Professor BRM, and said, you will never touch me. I'm never going to allow you to operate on me. And he was stunned because he was the doyen of neurosurgery. People were waiting months to get a glimpse of him, and to be even in his theater list was a great privilege. And he said, why would this lady do that? And so he turned to her and he said, why are you so against my operating on you? So she said, I'm not against surgery. I know I need surgery, but you are not going to operate on me for the simple reason, he said, you never even put your hands on me. You never felt my pulse. You never touched me. And you just looked at the film and you wanted to operate on me. She said, that will never happen. So he said, I learned an important lesson. Since then, he said, every patient who comes to me, no matter what, I know the diagnosis, I know what I'm going to do, but I'll first take the pulse of the patient, I'll catch her, feel her pulse, and then reassure her, and then him or her, and then only go on to describing the procedure and so on. So he said, that was a lesson that lady taught me, and this is what I'm sharing with you today. So that got me thinking, about the art of medicine and the conflict between the art and the science. So the last 25 years, this has been, at the back burner, at the back of my mind all the time. And so often I have thought about it, sometimes been vexed about the topic, but eventually, some kind of clarity has started to emerge in my mind, which I intend to share with you all. So, first of all, is medicine a science at all? Medicine is, of course, as Madam very nicely said, is a science and practice of caring for patients, making a diagnosis, prognosis, prevention, treatment, palliation of their injury, disease, promoting their health. We know all that. But is it a science? You'll be very surprised to know that there are many pure scientists who would really, scorn if somebody said medicine was a science. A very good example of that was the greatest, one of the greatest sons of our soil, the Nobel laureate C.V. Raman. When he started the Indian Science Academy in 1934 in Bangalore, he did not permit medicine to be included in it. Now, he said very clearly that medicine is not a pure science. And he said that's not going to be included in it. It took several years and several arguments before medicine was eventually included in the curriculum of the Indian Science Academy. And today, of course, it is accepted as an applied science. But there has been no doubt that even today there are many pure scientists who would look at you like a specimen if you said that I am, a scientist. I had a very interesting experience not so long ago when Dr. Abdul Kalam was the president, and there was an international conference on photonics hosted by St. Joseph's College in Trichy. And Dr. Abdul Kalam was a former student, alumnus of the college. So he was asked to preside. So he had come over. And I had been asked also as a former alumnus to make a presentation on the effect of lasers and the application of lasers in surgery. So I went there, and I was sitting there before my talk about an hour before, listening to the deliberations. And of course, needless to say, with pure physicists discussing about the various properties of light and laser, which is what photonics is about. Nothing, I couldn't understand a word of what was being said. It was all really in Greek and Latin. It was all theta minus alpha, would be so much, and therefore it would be equivalent to infinity and so on. So, and this is complete jargon. So I was listening to all that, and then after that, I was asked to come and give a talk. So as soon as I went up to the podium, I said, I have two confessions to make. I'm going to talk to you all in English. You'll have to apologize. I apologize for that, but it's going to be a talk in English. And secondly, I said, I'm really a foreign body in this crowd, so you'll have to put up with me. But I'm going to talk about, what all your deliberations eventually end up doing. So this is going to be the application. So I at that conference and that meeting, I recognized the fact that a pure scientist would never accept me as a true scientist. I would at best be a person who practices the application of science. So even today, this prejudice does exist. But then things have happened. We can't be always on the defensive. We have to also show that we have, science on our side. And we know that there have been many miracles of modern medicine. Several advancements have happened over the last century. Since 1900, the average life expectancy globally has more than doubled. It's now well above 70 years. So it's a huge achievement. And that would not have happened if this was mumbo jumbo. Technological, medical, scientific improvements have all happened to make lives of people much better. The quality of life has improved. You can be it 3D printing or gene splicing or bionics. We have tremendous advancements happening in every field. And every aspect of medicine has seen tremendous changes. In my own field of otolaryngology, the last 20 years has seen the field completely changed, standing topsy-turvy. When I trained to be an ENT surgeon in the UK, in one of the most prestigious hospitals in the world, in 1980s, what I learned then, I can tell you with confidence today that I don't practice any one of the surgeries that I learned there. It's all become obsolete. So, in a good 40, 45 years, the specialty has turned upside down on its head. Today, in my specialty, things happen which is nothing short of miracles. Take, for example, cochlear implants. A child has been brought to me with complete, profound deafness from birth. I can intervene in the child, and this child can 20 years later be somebody. Children I have implanted 20 years ago are now in IIT or in IIM. I have one boy who's in Harvard Law School who speaks 6 languages, including Spanish and French. So that's the miracle of modern medicine. Even more miraculous, even somebody who has not got a cochlea, who has not got an inner ear at all or a cochlear nerve, can receive a brainstem implant today and still be able to hear. Similarly, somebody who has lost the larynx due to a cancer of the larynx can have fluent speech thanks to voice processes, which is surgically embedded. So these are the kinds of miracles, modern miracles. So when we said deaf shall speak, or when we say that the deaf shall hear and speak, it is truth, nothing but the truth. And this is the miracle which has happened in the last, century or so. And in fact, I've just given examples from my own field, but this I'm sure has happened in every single specialty of medicine, be it cardiology, neurosurgery, cardiac surgery, you name it, ophthalmology, every single specialty has seen tremendous changes in the last century and particularly in the last couple of decades. But then the goal of medicine has never changed from ancient times. The alleviation of pain and suffering has always been the goal. And all these innovations have played a major role in advancing that goal and making possible medical treatments which achieve this goal. Our own tradition, has been very, very rich in this. 2,500 years ago, the savant Valluvar said this beautiful Tirukkural, is something which I cherish. Noi nadi, noi mudal nadi, adu tanikkum vai nadi, vaipach chayal. Each is pregnant with meaning. Noi nadi, it's no use that the physician stays in his ivory citadel and expects the patient to come to you. You have to go seek the disease, seek the patient, seek the illness. And this is why the new technique which has started now, the new enterprise of the government of Makkalai Thedin Marthuvam, it's a huge step forward. That is, we seek the patient and we take our medicine to the patient. So Noi Nadi. The second is Noi Mudal Nadi, to seek the source of the illness, epidemiology, in effect. So it was very, very clearly enunciated 2,500 years ago, even before the concept of epidemiology came in our school of medicine. And then comes the Adu Tanikkum Vayanadi. Then look at the way you're going to offer solace. How are you going to treat the problem? And finally, I think the most important of all this, Vaipachaya, give it in a way which is acceptable to the patient, which is embraced by the patient. Give the solution to the patient in a form that is acceptable to him. There's no use in giving a medicine with beef extract to a Jain. He's not going to take it. Or forcing a Jehovah's Witness patient to undergo blood transfusion. Now, you may achieve it, but then, at what cost? You're not going to have a happy patient at the end of it. So therefore, you have to also give it in a form which is acceptable, palatable to the patient. So each one of those words was very, very important. And believe me, I'm astounded when that this was a thought process 2,500 years ago. Of course, our present school of medicine, which we all embrace, it has its origin in the Greek school, which is also equally, rich in its tradition. Hippocrates, of course, and Asclepius, who was then deified as a god, were great figures. All of us know Hippocrates. We've all taken his oath. But then, very few of us actually look at all the wonderful things that he said. He said, I will remember that there is art to medicine as well as science, and that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. And he said, wherever the art of medicine is loved, there is also a love of humanity. Such important and meaningful words. In the earliest Greek texts, medicine is described as a technique or know-how. It conveys elements of science, of course, but also art and skill and artisanal craft. Because don't forget, the Greeks thought medicine was a very much a craft, just like weaving, just like painting. It was considered an art. The goal of medicine has always been a relief of suffering. We have already said that. And the word patient itself comes from the Latin patientem, meaning sufferer. The word physician is from the Greek physis, or nature. In other words, to be engaged in clinical work is to engage oneself with the nature of illness, the nature of recovery, and in fact, the nature of humanity. So, can art assist science to bring about change? Aristotle termed the practice of medicine phronesis, or practical reasoning and wisdom based partly on science but mainly on experience and judgment, a fact which our revered Vice Chancellor undermined in her introduction. So, how does art help science? Take, for example, the example of Semmelweis. Ignaz Semmelweis was an obstetrician. In 1848, he found out that puerperal sepsis was greatly reduced from something like 12 to 2% by simple process of introducing hand washing and washing medical instruments with a chlorinated lime solution. However, his theories were absolutely dismissed. Nobody took him seriously. And the simple reason was that he was described as an obnoxious and an abrasive character. So he just did not know to practice the art. Hence, the science, even though it was very sound and well proven, was never found its way into the clinical practice. This is a very good example. But the practice of medicine has to be, therefore, in a manner comprising both compassion and evidence, so that we may truly heal those with whose care we are entrusted. Da Vinci said, study of the science of art, study the science of art, study the art of science, develop your senses, especially learn how to see. Realize that everything connects to everything else. And Paracelsus, the Swiss physician, who's even today considered as the father of chemistry and biochemistry and pharmacology, and particularly toxicology. He said medicine is not merely a science but an art. The character of the physician may in fact act more powerfully upon the patient than even the drugs that he employed. And here you can see the mosaic on the floor of Asclepion, of course, depicting Hippocrates with Asclepius in the middle. Asclepius was a physician of great repute. He actually emphasized the need for documentation, of documenting every finding in the patient, and showed wonderful cure and results, so much so that he was deified. And even today, his school, the Asclepion, we can go and visit, and you can see a statue of Asclepion holding the staff, and which is the staff of which is symbolic of medicine. And you can all see that unlike the staff that we see today depicted everything, there was only one snake. There were not two snakes. So one of the things which struck me when I went and visited the site myself a few years ago. But that is Asclepius. Today, many great breakthrough treatments, research, medical devices have had huge impact in the world of medicine. In my own field, today cochlear implants has given hearing to otherwise children would have been deaf and dumb, and in fact has given hearing to more than almost 1 million children. In the state of Tamil Nadu alone, more than almost 5,000 children have received cochlear implants, and has completely changed their quality of life. So today, thanks to technology, there is better and more accessible treatment for a wide variety of diseases, and much better and more efficient care for the sick, and also better health care and disease control. So then comes evidence-based medicine. This is, of course, a mantra that all of us are using, and we are used to listening to this all the time. Evidence-based medicine is a contemporary movement to establish effective algorithms of practice through the use of systematic reviews and meta-analysis. After evidence-based medicine was established as the new form of medical science, the art and science of medicine had to be connected. The end of 20th century, healthcare had become highly dependent on technology. From electronic medical records, telemedicine, 3D printing, algorithms, and sensors, technology has started to influence medical practice and the lives of patients like never before. And the art and the humanistic components of medicine is now at the back footing, it's on the decline. And the debate over the status of medicine as an art or science still is, in my mind, it continues. But medicine, no doubt, cannot be just an applied science alone because of the pure uncertainty in medicine. So, what about the dichotomy between art and science and medicine? According to Catherine Montgomery, who wrote this very nice book, How Doctors Think, which I would recommend to every medical student. Art science duality, according to her, is a false conception of what clinical medicine is. She sees it as just two sides of the same coin. Theodore Fox, who for many years, almost 20 years, was the editor of Lancet, said the patient may be safer with a physician who's naturally wise than with one who's artificially learned. The practice of clinical medicine with its daily judgments is both science and art. And what are the impediments to practicing the art today? The commercialization of healthcare, in my mind, is based on the science and to the utter neglect of the art, as it benefits the care providing corporate facilities. Modern medicine revolves around health maintenance organizations, pre authorizations, claim denials, consumerism, governmental bureaucracy, and hospital administrators, often young enough to be our children, telling us how to practice the art of medicine. But for great physicians who practice the art of medicine, medicine is no longer becomes a living, but rather a way of living, rather a way of life. About corporatization of healthcare, which is now, of course, a fact of life in medicine. It dictates the delivery of healthcare as per standard operating procedures. An individual's experience of their art and hence the transformative path to become a physician artist is blocked. The rules are set in the boardrooms, the paycheck guaranteed, the creative thinking at the bedside is vanquished. The result is a joyless practice of medicine, devoid of medicine's artistry and burgeoning with frustrated physicians. This accounts for the current rise in physician burnout across all segments of medicine, often at a very young age. Corporatization of healthcare also leads to doctors who want shift work, who see the relationship with their patients at an arm's length transaction, who value their private time more than their patients' comfort. They will thrive in today's world of doctors. But when judged through the great medical icons, they have settled for less. We physicians have always dealt with the three aspects of the human experience: the body, the mind, and the human spirit. As my years as a surgeon expanded, I realized my own perspective that the priority had shifted from the body more towards the other two, with an increasing realization of my own failings and frailties as a doctor. In the art of medicine, physicians themselves become the diagnostic and therapeutic instrument that apply the knowledge and skills of medicine. The art of medicine includes not only the knowledge required for the diagnosis and healing, but the ability to apply the knowledge to the individual. This is what Valluvar said when he said, Vaipachayal. An impersonal computer can dispense the science of medicine, but only a caring physician with empathy can practice the art. So then comes the interesting concept of disease and illness. Disease is a pathoanatomical or pathophysiological entity that manifests its symptoms that the patient experiences and the doctor discovers. Diseases are abstractions that have no concrete existence except as instantiated in particular patients. Illness is the patient's experience, however, of the effect of the disease. So, what the disease does to the patient and his experience is what amounts to the illness. It includes not only the symptoms, but the interpretations and meanings of the symptoms. It also embraces the impact of the altered function or behavior and social existence. In short, illness is a much broader concept than disease. It is with illness that the patient presents to the physician, while the physician is primarily interested in the disease. The ethicist should be concerned with the illness because of its effect on the patient, his or her relationships with the community that put in doubt the moral agency of the sick person. William Osler, the Canadian physician, was a great doyen of medicine and one of the four who started the Johns Hopkins Hospital, said the good physician treats the disease, the great physician treats the patient who has the disease. How true can that statement be? Osler believed that medicine arose out of a primal sympathy of man with man, out of a desire to help those in sorrow, need, and sickness. In short, empathy. So, William Osler also said the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. He noted that the practice of medicine is an art based on science. And he also said the old art cannot possibly be replaced by, but must be absorbed in, the new science. What wonderful sentiments. The diagnosis and treatment of a disease will often depend on multiple variable and unpredictable factors, a fact which is again underscored by Sir William Osler. Let us look at the effect of the individuality of the patient on the disease process. Onset, course, treatment, outcome of identical diseases vary from patient to patient because of individual variation right from the molecular level to the whole person to the community. The contribution of the individual to differences in his illness is sometimes difficult to appreciate if one thinks only about the acute infectious disease or the trauma. Chronic diseases, which produce the greatest burden of illness, will give a much better example of this. Take, for example, diabetes in adults. We all know it's genetically determined, but its severity and course are determined by variations in diet and exercise pattern from person to person. And because disease is a process that occurs over time, the responses of the disease manifestations becomes part of the illness itself, as they alter the patient's behavior and change of illness. For example, the compliance of the patient to his medication, his exercise regime, and so on, can greatly alter the way the disease manifests in the patient. Each modification requires a change in the approach of the physician, dictated for the most part not by medical science, but rather arising from the doctor's art. The physician can affect the patient and his illness only through the doctor-patient relationship, which is central to the practice of medicine and its art. But differences among individuals, for example, their trust versus suspicion, openness versus shyness, or friendliness versus hostility, will influence the kind of relationships formed between the physician and the patient. The differing perspectives of the patient and the physician. Although doctors and patients may appear to speak the same language and the same subjects, their viewpoints may differ. The care of the terminally ill often exemplifies this dissonance. Here, one of the ends of medical science, which is staving off death as long as possible, may be at odds with the patient's desire not to be in pain or suffering. A necessary aspect of the patient's art is a physician's art is to understand the patient's goals and adjust professional aims and medicine's tools to this end. I'm reminded of a particular patient, a lady in her 70s who had a terminal head and neck cancer. She had undergone multiple procedures, surgeries, radiation, chemotherapy, and eventually ended up with a very gory fistula in her oral cavity, leaking saliva and infested with maggots. Every time she used to come, I used to see her once a week, do her dressing, clean the wound, clean the maggots. Every time she came, she had only one question: Doctor, am I smelling bad? I would look at her with a straight face and tell her, no, ma'am, just give us a few minutes. We'll clean this and then you'll be smelling fresh as a daisy. A few months later, I had gone away from the country for a meeting. And when I came back, her son came and met me with a letter. He said, my mother died, and you're not here. And she left a letter, doctor, for you to read. And she told us that it should be handed over to you. When I opened the letter, she said, doctor, when you receive the letter, I will no longer be in this world. My body and my soul, my blessed soul would have left this miserable body. But I just wanted to thank you. Every time I came near you, I knew I was stinking. You never showed it on your face. You cleaned me up and dressed me and sent me back. And every time I used to ask you the same question, and with the same smile, you told me, you'll be smelling as a daisy. My husband was married to me by 50 years, and all my children whom I had given birth to used to show it on their faces every time they came near me, but you never did. So, doctor, thank you for that. That is all that I wanted to say. So, her only priority was that she should not be a source of nuisance to her immediate surrounding. The doctor in me was always trying to prolong her life. So, that is the dissonance that I'm talking about. The art and science of medicine are complementary. The art of medicine, and it has to be complementary. The art of medicine deals with the whole gamut of doctor-patient relationship. Patient's interest, concern, or welfare all come first. The plethora of diagnosis and treatment options are all secondary and subsidiary to the patient's welfare. So what about care versus cure? An exponential growth of technical competence and the effectiveness of care has been paradoxically paralleled by a decrease of trust. One would have thought that with the increasing technical competence, trust would have grown up. But what we see now in the last few years is a decrease of trust, and due to mainly, in my opinion, the lack of empathy between physician and the patient. There is no doubt the social, psychological, and behavioral dimensions of this illness should be considered in addition to the physical dimension. A doctor's bedside manner is comforting in comforting the afflicted patient is as important as a doctor's actual treatment. So let's not take, for example, the proverbial blind man and the elephant. This particularly happens when you have a patient who has multisystemic problems and is being treated by several physicians from different specialities. Each is looking at the elephant from his own perspective, forgetting the bigger picture. And the patient's trust in the medical profession suffers considerably at the end of the exercise. Tucker described medicine as an art as well as a science. We all know this, but over the ages, this art-science ratio has undergone a dramatic change, he bemoaned. The medical pendulum is swinging from the art to the science. And in my opinion, the best clinician is one who, armed with the scientific knowledge, practices using excellent clinical judgment, which of course is his art. Compassion and understanding are a large part of this art. What about the doctor-patient relationship? Let's continue with this. This special relationship has been appreciated since antiquity. Valluvar said, "Utran alavum, pini alavum, kalamum, katran kardi chayal." So this was his plea to the physicians, so the doctors. He said, understand his problem, the quantity of the problem, the time, and then carry out your actions based on your knowledge. As much a part of sickness and medicine as a disease that makes the patient-doctor relationship makes a sick person a patient and a physician and a clinician. So it is a vehicle through which a physician exerts his authority, without which the practice of art is impossible. The bond between the doctor and the patient has often been described as sacred. It's effective across cultural boundaries, even in the presence of antagonism, despite formidable social and environmental impediments. All of us have treated patients from Pakistan. They are still the same grateful patients, no different from our own patients, despite their many prejudices. So these prejudices do not apply in our branch of science. And simply because of the way the art is practiced. Physicianhood, in my opinion, is a set of performances, duties, obligations, entitlements, and limitations. The socialization of a medical student includes learning about the doctor's role so that they emerge as physicians and in the role of physicians. It also has its counterpart in the patient, who provides for the doctor's words and actions access to the patient and his body, not available to ordinary relationships. So it's a very, very special relationship. Because of this relationship, physicians are enabled to see the authentic person through the maze of sickness. Doctor-patient communication. The ability to use a spoken language to obtain information about the patient, gain his cooperation, and provide information to the patient is central to the art of medicine. The importance of verbal communication is equally matched by the non-verbal aspects of communication, which the patient may not be aware of, but the astute physician learns to detect and interpret. You may wonder what this has to do with the art. Well, it has everything to do with it. I'm reminded of a very interesting study which came from the Department of Neurology at Stanford about, I think, a good 10 or 15 years ago, in which a group of volunteers were divided into two categories. A younger set of volunteers, medical students, who all belonged to the young digitally active group, and they were classified as digital natives. Another set of physicians like me, who had not born into the digital age but had to learn through hard work the use of digital technology, were classified as digital immigrants. And when functional MRI was carried out, to the utter surprise of the investigators, it was found that while we senior doctors who were digital immigrants mainly used our left hemisphere, the younger generation tended to use more and more of the right hemisphere. So they concluded that the generational shift in medical community was not only a generational gap, but also a neurological gap. So it's very interesting indeed. So, and this came back, begs the next question: what does the difference mean? The difference means, of course, that the more and more the right hemisphere comes in, more and more the conceptual part of the brain is being used, and they may understand a few concepts much better than us, but in the process they may also lose a little bit more, which is mainly the non-verbal aspects of communication, which is to understand the patient's body language. When this troublesome patient comes and sits in front of you, within 2 minutes the senior physician recognizes that this is a troublemaker and tries his best to keep his guard and keep everything going smoothly. That this is the aspect of non-verbal communication which is sometimes missing when one is only looking at technology and not the art. These aspects of doctor-patient relationship are even contravened or obscured, as I said, in high-tech environments of modern medical centers. Patients' trust is essential for successful diagnosis and our outcome, and therapeutic intimacy arising out of successful relationships creates confidence. As part of their art, skilled practitioners actively nurture this relationship, negotiating between empathic intimacy and objectivity. To nurture this relationship, there are a few qualities which are central to a good clinician. First of all, a good clinician has to be a good person. And this is true as in times past, it is also true now. The art of medicine is rooted in the heart. If your heart is false, you will be a false physician. If your heart is just, you will be a true physician. It is difficult for a scientific and cynical era such as ours to accept the unavoidable necessity for virtue amongst doctors. Most medical schools have largely abandoned the active training of doctors in the virtues of a good physician. Even so, most medical students inherently learn this, even only through socialization or imitation, to be self critical, to pursue the good of the patient, and to act benevolently. Next, the question of AI in medicine. Is the rise of AI in medicine a threat to the art of medicine? There have been many who have raised this question with concern and who feel somehow that medicine is threatened or the art of medicine is threatened by the rise of AI. Despite common fears about the perceived dangers of automation and AI, not seeming, but let us look at the facts. None of these are seeming to be taking the jobs of physicians or monopolizing medicine. It will help automate administrative tasks, take over monotonous day-to-day assignments, no doubt. And I, for one, am optimistic. I feel that it has the potential, AI has the potential to free up time for medical professionals to fulfill their mission, which is to help people with compassion, creativity, and care. Art of medicine needs time, attention, empathy from physicians, time which is at a premium today in today's milieu of increasing electronic documentation and increasing pressure both from administrators and payers. So we need time, and to have this time, AI, I think, has a great potential of freeing us from the chores of this day-to-day burden that we all have to face. Advanced technologies have the potential to achieve and release the professionals from this rut. Compassion, empathy, creativity, problem solving, and profound human connection will never, in my opinion, cease to be at the core of caring for patients. If we embrace AI with the proper tools, policies, and education, the real art of medicine will begin a new era of art of medicine facilitated by artificial intelligence. George Engel, recognizing the need to know and be known as basic to humanity, asked the patient's name. Do my doctors know who I am, who I have been, who I still want to be? Do they understand what I'm going through, my suffering, my pain? Do they understand my hopes, aspirations, my fears and shames, my vulnerabilities and strengths, my needs and obligations and my values? Above all, do they sense my personhood and my individuality? Do they acknowledge my humanity? Do they care? What wonderful words. The importance of art of medicine is because we have to deal with a human being, his or her body, mind, and soul. Hippocrates again said it's more important to know what sort of person has a disease than to know what sort of disease a person has. So it's profound words. Peabody stated that significance of the intimate personal relationship between a physician and patient cannot be too strongly emphasized, for in an extraordinarily large number of cases, both the diagnosis and treatment directly depend upon it. Cecil's textbook of medicine, this introduction is wonderful sentiments expressed. Medicine is, I quote, a profession that incorporates science and scientific methods with being a physician. The art of tending to the sick is as old as humanity itself. Compared with its long and generally distinguished history of caring and comforting, the scientific basis of medicine is remarkably recent. Further, the physician is advised to understand the patient as a person. Three fundamental principles are important to the practitioners. They are primacy of patient welfare, patient autonomy, and social justice. The book also talks about the art of caring and comfort, guided by millennia of common sense, as well as a more recent systematic approach to medical ethics, and it remains a cornerstone of medicine. And without these humanistic qualities, the application of modern science of medicine is suboptimal, useless, and even detrimental. Take, for example, the medical practice in the COVID times. Nowhere is the disparity between the science and the art of medicine evident than in COVID times. All of us did teleconsultations online while serving to deliver essential medical care to numerous patients. It's nevertheless left a trail of dissatisfied patients simply because of the lack of physical contact and comfort. George Santayana said it's not wisdom to be only wise. So, to conclude, science has made impressive advances in the past century. A plethora of discoveries and advances have changed the face of medicine out of all recognition. In virtually every discipline of medicine, new and highly effective management modalities are available. However, the art and science of medicine are inseparable, just like the two sides of a coin. Medicine is an art based on science, after all. The application of medical technologies has contributed to the idea of bedside excellence as the primary tool and iteration in the patient physician relationship. Medical professionals use advanced technologies and care for their patients better. But medicine is not only a science, but a therapeutic art. Integrity, compassion, altruism, respect, service, concern for the patient, empathy, and wisdom are all vital to the practice and the art of medicine. In the final analysis, I teach my students very often that the good doctor cures 50% of his patients. He further ameliorates an additional 25%, but then he can certainly comfort all 100%. Finally, I conclude my talk with these parting words, thoughts of Sir Robert Hutchison, a wonderful surgeon who wore several hats, a great ophthalmologist. He was a great pulmonary surgeon, a general surgeon, a venereologist, a pathologist, former president of the Royal College of Surgeons. He said, from inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of the disease more grievous than the endurance of the same. Good Lord, deliver us. Thank you very much indeed.
Thank you very much, sir, for that wonderful, what do I say, lecture, speech, or the education, the enlightenment that you gave us. Professor Mohan Kameshwaran brought out several aspects of the patient-doctor relationship and how things should be. I was just checking the so-called Hippocratic Oath. Of course, what we have today is a kind of a translation, or probably one of the translations of the legendary Hippocratic Oath. The last paragraph of this oath goes like this, I quote, "If I fulfill this oath and do not violate it, may it be granted to me to enjoy life and art." And I think that is what Professor Mohan Kameshwaran gave us today. Thank you very much once again, sir, on behalf of the university, on my personal behalf, and on behalf of all members of the audience. And I liked every single word that you stated, especially the one about the perspective difference between the patient and the physician. The perspective of the patient and that of the physician will be different. I was reminded of the age-old adage, "Talavaliyum kaachalum thanakku vandathaan theriyum." When it is to the patient, it's different. But then when it is to our own selves, it is different. Thank you very much once again, sir. And I do find our Pitamaha there, Major Dr. Raja. Sir?
Yes, sir.
Thank
Yes,
you
madam.
for joining. Thank you very much for joining. And now to you, sir, your remarks.
I'm really thankful to you, and I'm very, very happy to listen to this great lecture by Mohan Kameswaran. I wish my great teachers, Dr. Kameswaran and Lalita Kameswaran, was today to listen to this boy, how he has delivered this lecture. And because I known him from his childhood, and how he grown to a big ENT surgeon, and I'm really very happy, Mohan. Congrats to you, and I'm very happy. This lecture should come in the YouTube and other thing, so that the people and the students can listen to it. And I also want to listen one more time, so that kindly make it available to the people, so that anytime they can refer it. And I once again I thank the Vice Chancellor Dr. Sudha Seshian for bringing me to attend this lecture. And one more time,
Thank you.
God bless you.
Thank you. Thank you. Thank you, sir. Thank you. There are very few people in this world who will call me a boy. I'm really quite touched by it.
I got a
At
liberty,
66,
Mohan.
yes, sir, I know. At 66 years, you don't get called a boy very often.
Yeah, thank you.
Thank you,
sir.
sir. Thank you. The university is privileged to have people like you to guide us and, take us, handhold us and take us along the right path. Thank you very much, sir. And Professor Ganapati is here. Sir?
Dr. Sudha Seshan,
Yes, sir.
one more thing. Mohan Kameswaran's father, Dr. Kameswaran, in 1955, he gave me a certificate, medical certificate, as well as a contact certificate to be joined as a medical student.
Oh,
And his mother only has made me as an administrator. I owe so much to these, both the people, Kameswaran as well as Radha Kameswaran. I can never forget them in my life. They have molded me what I am today.
sir.
So that is, I owe so much to this family. Thank you.
Sir, not only you, sir. I think all of us owe so much to both madam and sir. Ranjit
Yeah.
would agree with me. Ranjit, you and me were students of Madam Lalita Kameshwaran. And then I think everyone, at least in the state of Tamil Nadu, would look at them with respect and remember them forever.
Yeah.
And that is why I said, sir, in the introductory remarks when you hadn't joined,
Yeah.
Dr. Mohan Kameshwaran is a descendant of the first family of this university.
Yeah.
Family of this university will permanently be Dr. Mohan Kameshwaran's family.
Thank you, madam. Thank
No
you.
doubt about it. I agree.
So
10%
much.
agree with you.
We all owe so much, sir, and thank you very much. And Professor Ganapati, sir, your words, please.
Yes, thank you, madam. I would just like to say a few words. First of all, Mohan, I'm able to relate 150% to every single statement you made. Though you were 3-4 years junior to me, we essentially belong to the same generation. I was the last student who was formally trained by Professor Ramurthy, of course, partly. And of course, I was Dr. Lalita Kameshwara's student also. Major Raja, sir, I don't know whether you remember, though you were several years senior to me, we were postgraduates together, sir, and we did night duty together. You were DAOS and I was DANS, though you were several years senior to me.
I'm a friend to the old as well as young people. I can adjust with anybody.
I just wanted to make a few comments. See, neurosurgery, particularly in the last, I belong to the BC era, not before COVID, but before computers. I was the last neurosurgeon in India who got an MCH degree before even the CT scan came into clinical use. So Dr. Ramurthy, Kalyan Raman, Arjun Das, Jagannathan, every one of them taught us to make a diagnosis from the history. Sir William Osler said 160 years ago, listen. He is telling you the diagnosis. I belong to the group, madam, who were taught not to treat an MRI image, not even to treat the tumor, not even to treat the system, not even to treat the patient, but to treat the family of the patient. And Dr. Ramurthy has blasted me several times. I presented clinical cases. I even did perianal anesthesia, anal reflex and things which no medical postgraduate would normally do. But instead of complimenting me, he said, you don't even know how many grandchildren this patient has. What sort of a doctor are you? You want to become a neurosurgeon. I mean, that was the background in which we were brought up. Again, Lars Lexel, the inventor of the gamma knife, he said, the gamma knife was the most sophisticated technology 55 years ago. He said, a fool with a tool is still a fool. In other words, it's a man behind the machine that counts. Mohan, you may perhaps remember, you were kind enough to refer several patients to me for stereotactic radiosurgery. At least 3 patients, I sent them back to you. Even though you are the ultimate authority in all this, I sent them back to you and I said, it's against my conscience to offer a treatment when they've got excellent, preserved, useful hearing. I do not treat shadows just because there's a 7 millimeter intracanalicular adenoma, which is so amenable to cyberknife radiosurgery. It's against my conscience to intervene when such intervention is not necessary. This is because I read long ago, and I've seen it in my own practice of 45, 48 years. All people with brain tumors do not die of brain tumors. They die with brain tumors. There are hundreds of patients with for whom CT scan was done for head injuries, where we have picked up what we call an incidentaloma. an incidental meningioma, and so many of these cases, mild hydrocephalus, etc., absolutely asymptomatic, and it's against my conscience to do any treatment which is not clinically indicated. And I'm very sorry that today, 2021, technology has become such a major issue that I totally agree with you. It is very sad. And madam, I think the university can play a major role, sensitize the younger doctors today. This lecture should have been listened to by every single medical student. You demonstrated the art and science of giving a lecture, and I could see your heart as much as your head when you showed all these wonderful slides. You obviously have put in a lot of effort and time to make it scientific. The entire presentation was very well thought out, etc. So I am very concerned, as one who is 71 years old now. I'm very concerned that today we are using PET MRI and PET CTs. We never bother to ask a person with a tumor or multiple tumors with secondary deposits. You decide on, you give him the different options of management. How many of us ask the family, why do you want treatment? What sort of a treatment do you want? I mean, I could go on and on, but I'll just conclude with one example. I remember in 77, I was a third year postgraduate, MCH. We had a Bhagavatar with a left temporal Broca's area glioblastoma, of course, based on angiographic diagnosis. And but with the treatment then available, maybe we could have given him 4 months more of life or 5 months more of life. Now, we had a ward round every Wednesday morning. We have a wonderful clinical meeting, and Friday morning grand rounds. So in the grand rounds, I mean, I was 18 years junior to Dr. Ramamurthy, but then I just told him, sir, anyhow, he's not going to live long. And why don't we just leave him alone, sir? Let him at least sing for the remaining few weeks of his life. I mean, this probably would have been treated as an absurd statement. A big institute of neurology, Madras Medical College, saying no treatment. But Dr. Ramamurthy was such a fantastic person. He listened to me, and then he said, well, maybe there is something in what you say. And then we discussed in the family, and we decided not to treat the patient. He died 8 weeks later, but the family was so happy and the patient was happy that till 4 days before he died, he continued to sing, which was what he lived for. So I really think we should take into account what the family wants, not just offer them all sorts of sophisticated treatment, which we are familiar with. Thank you once again. I really enjoyed this talk, and I've learned a lot of things. Thank you, Dr. Mohan. It was excellent.
Thank you. Thank you. Thank you, Dr.
Thank you very much, sir. And as a matter of information, I've already requested Professor Mohan to give us the write-up so that the university would take it forward and publish probably a booklet on it, or add it up to one of our proposed publications. We'll bring it out, and this particular lecture is already in the YouTube. It had been listened to by several people through the YouTube. The Zoom link is given only to a restricted lot, not to everybody, but then it goes into the YouTube live, and this will be in the university's YouTube channel forever, sir. It will be there. And Dr. Ranjit, would you want to say something?
What more do I have to say? It was a wonderful talk. Truly, honestly, thought-provoking lecture, Dr. Mohan.
Thank you.
Professor Mohan. And also, like, I fully agree with Professor Ganapathy. Maybe it's time actually somebody takes this initiative. And I request our Vice Chancellor to make it, like possible for the new generation to understand what we, what the future generation is probably going to miss. If nobody is going to initiate this particular concept into the minds and also the practice session, during the lifetime. So thank you very much, Professor Mohan. It was a wonderful.
Thank you, Ranjit. Thank you.
Thank you, Ranjit. There's only one point on which I would conflict with Professor Ganapathy. Sir, you said 71 years old. Please stand corrected.
Young, I said young. Madam, I said 71 years young.
Yes. Dr. Ravindra Mohan has joined us also. He was here through the lecture. Sir, you have
Yes,
any
ma'am.
remarks to make? Yes, sir.
Yeah, there seems to be some problem with my video. I think it's okay now. Very, very lovely talk. Really enjoyed every word of it. Just a couple of questions, Dr. Mohan. One is the phenomenon of electronic medical records, documentation like NBH, JCI, both of which require more time spent on the part of the physician to make sure things are fine. That reduces the time and interaction with the patient. The second is the computation from Dr. Google. Most patients are very informed.
Yes.
I myself consider it to be a double-edged sword. A well-informed patient is also a better patient in many ways, but not always necessarily so. So I just wanted your opinion on these two phenomena, which are quite prevalent today.
Excellent questions. Very thought-provoking. I don't think there's a straightforward answer. I think the answer varies from patient to patient, actually, based on the quality. But end of the day, all of us confront this. Patients coming with sheaves of paper printed out, knowing all about the disease, sometimes even more than what we do know. But the basic fact, I tell the patient that, Dr. Google never solved a problem. He never solved a problem. If he did, then you wouldn't be coming and looking at me. And the ultimate final analysis is like what Dr. Ganapathy said, that you have the science there, but end of the day, it is the clinical science, the examination, so many things that you pick up, which no Google is going to tell the patient. And these are things which helps to build the trust between the patient and the physician. When you point out those things to him, discuss the various options to him, and give him options which maybe in the Google doesn't offer to him. Those are the things which ultimately build the trust. And I believe it is the trust which is finally going to overcome this hurdle that we are going to face. And as for the documentation, I think it is important, that the documentation may take the time of the physician, but in the final analysis, the longer, long term, it will also release more time for us in many ways, because you may also save time in the long run when you have excellent documentation, which you can fall back upon. So this it works both ways. So I think documentation is important. And as I said in my talk, artificial intelligence, if it's used properly and judiciously, has the potential to actually release more time for the physician to carry out with his, actual practice of medicine with the empathy that is required. So I think it is something that will work in our favor, provided we use it judiciously.
Thank you.
Thank you, sir. May I request any other member of the audience for any opinion, remarks, questions? If there are none, I think we are duty bound to thank Professor Mohan Kameshwaran once again. Sir, I think you have left every one of us speechless. You have kind of put in that feeling, that feeling in the minds of each one of us who is listening, as to we would want to kind of set the clock back and start all over again. The kind of feeling that you have, like, okay, let me go back and correct everything and let me start everything anew. That kind of a motivation you have given us. Thank you very much for that. And what else do I say? Words fail me, sir. Thanks a lot. Thanks very much.
Thank you, madam. Thank you so much. Thank you for the opportunity.
Thanks, Professor Raja, sir. Thanks, Dr. Ravindra Mohan.
Thank you,
Professor
thank you,
Thank you, madam. Thank you.
thank you, thank
Really
you, thank you.
enjoyed the
everyone.
talk.
Thank you,
the
everyone.
opportunity.
And Professor Mohan, sir, please remember to make this into a script and.
Yes, ma'am. I will do that. I won't forget.
Thank you, sir.
Thank you.
Thank you very much.